Hello, my name is Allison and I am a fourth-year nursing student doing my placement at the bariatric clinic. The purpose of this video is to understand the link between obesity and liver disease. The topics being covered in this video are understanding the liver and its functions, looking at obesity and how obesity affects the liver, looking at non-alcoholic fatty liver disease, the prognosis, clinical presentation, risk factors, diagnosis, treatment, and bariatric surgery. The liver has many important functions in the human body. First, it prevents shortages of nutrients by storing vitamins, minerals, and sugar. It produces most proteins needed by the body. It produces bile, a compound needed to digest fats and to absorb vitamins A, D, E, and K. It produces most of the substances that regulate blood clotting. It helps your body to fight infection by removing bacteria from the blood. It metabolizes or breaks down nutrients from food to produce energy when needed, and it removes potentially toxic byproducts of certain medications. Next, we are going to look at obesity. Obesity is one of the greatest 21st century public health challenges. Currently, more than 2.1 billion people, approximately 30% of the global population, is overweight or obese. Obesity is defined as an abnormal or excessive accumulation of fat that may impair health. According to the World Health Organization, any individual with a body mass index greater than or equal to 30 kilograms per meter and severe or class 3 obesity is defined as a BMI greater than 40 kilograms per meter. How obesity affects the liver. As obesity and type 2 diabetes is on the rise, the prevalence of non-alcoholic fatty liver disease is also increasing. When there is an expanse in adipose tissue, this can disturb the normal storage and endocrine functions of the adipose tissue. Non-alcoholic fatty liver disease manifests when the synthesis of fatty acids in the liver exceeds the export or fatty acid oxidation. This increase in free fatty acids leads to an altered metabolic state with insulin resistance. Insulin resistance then leads to hyperglycemia and reactive hyperinsulinemia, which stimulates the lipid accumulating process and impairs hepatic lipid metabolism. The insulin resistance also enhances delivery of free fatty acids to the liver from the adipose tissue due to uninhibited lipolysis. All these changes result in abnormal fat accumulation, which further aggravate the metabolic state. Non-alcoholic fatty liver disease and NASH. Non-alcoholic steatohepatitis, NASH, is a term that was developed in 1980. However, the term non-alcoholic fatty liver disease, or NAFLD, has been adopted to cover the full spectrum of metabolic fatty liver disorders. NAFLD refers to the accumulation of fat, mainly triglycerides, in hepatocytes that exceeds 5% of liver weight. NAFLD has a very high prevalence in North and South America, much of Asia Pacific, including Australia and New Zealand, the Middle East, and Europe, and is the leading cause of a referral to hepatology clinics in most regions. However, NASH has been referred to as a disease of the West, due to altered socio-economic circumstances, problems with food intake, food composition, and a lack of physical activity. NAFLD, or NASH, is now regarded as a manifestation of the metabolic or insulin resistance syndrome, and the link between obesity, type 2 diabetes, cardiovascular disease, and more. NAFLD is more prevalent in men, and genetic factors as well as age are associated with the diagnosis. The progression of liver disease. Simple fatty liver. Excess triglycerides build up within the hepatocytes. Complete resolution can be expected with weight loss, and typically there are no symptoms, although some patients may complain of right upper quadrant dull aching pain. This is frequently diagnosed as an incidental finding on an ultrasound scan. The next stage is non-alcoholic steatohepatitis, or NASH. This is a more aggressive form of the condition characterized by an inflammatory cell infiltrate into the liver, and as a result, hepatocyte damage occurs, called ballooning degeneration. Fibrosing NASH. Some NASH progresses to fibrosis due to persistent inflammation of hepatocytes. There is generation of fibrosis scar tissue around the liver cells and blood vessels, with fibrosis tissue replacing some of the healthy liver tissue. Due to natural redundancy of hepatocellular function, there are enough hepatocytes to maintain liver function. Therefore, completely normal liver function tests may be present even in the presence of active inflammation and progressive fibrosis. Fatty liver, or steatosis, is the pale appearance of blunted-edged liver on gross inspection and simple fat infiltration with no inflammatory cells on histological examination. It's defined as fat accumulation exceeding 5% of fat hepatocytes identified histologically. Cirrhosis. Even at this stage, blood tests may be normal, however, they deteriorate as hepatic damage accumulates and hepatic decompensation occurs. Standardization of the histological diagnosis of NASH is achieved by using validated Kienler NAFLD activity score, which defines steatohepatitis by grading the degree of steatosis, lobar inflammation, and hepatocyte ballooning degeneration, and quantifies fibrosis. Some patients will have a clinical presentation. They may complain of fatigue or malaise and a sensation of fullness or discomfort in the right upper abdomen. Health-related quality of life is significantly diminished due to insulin resistance-associated comorbidities. Risk factors. NAFLD may affect any age and ethnic group. The differences in body fat distribution and body composition can play a role in the prevalence of NAFLD. A more central obesity phenotype is associated with increased visceral fat. Visceral adipose tissue has a greater potential to release free fatty acids directly into the portal circulation. In comparison, free fatty acid concentrations in individuals with predominantly lower body obesity tend to be normal regardless of the BMI. In addition to central obesity, type 2 diabetes, dyslipidemia, and hypertension are all risk factors for the development of NAFLD. Environmental factors and a lifestyle promoting less physical activity and high-fat diets are well-known influences for the development of insulin resistance-associated comorbidities and NAFLD. Diagnosis. The diagnosis of NAFLD requires the exclusion of alcohol abuse and other etiologies as the cause of the liver disease. NAFLD is most often diagnosed in asymptomatic persons after the detection of raised aminotransferase during routine screening or abnormal hepatic ultrasonography performed for another purpose, such as the suspicion of gallstones. The basis for metabolic liver disease can be revealed by a personal and lifestyle history documenting recent weight gain or expansion of abdominal girth. Patients with cirrhosis may also present with gastrointestinal bleeding from portal hypertension or with muscle weakness, ascites, jaundice, or hepatic encephalopathy. Physical examination of patients with liver disease should now routinely include anthropometric measurements like body mass index and abdominal girth, and a diagnostic workup of NAFLD should include fasting serum lipids, high-density lipoprotein cholesterol, low-density lipoprotein cholesterol, and blood glucose. In addition to these metabolic tests, a test of insulin sensitivity should also be performed. Hepatic imaging will provide an evidence of steatosis, and only through a liver biopsy will you be able to confirm the presence or absence of NASH in a person with features of NAFLD. Treatment. Attempts to treat obesity constitute first-line therapy in patients with NAFLD or NASH. Thus, early intervention should attempt to increase physical activity while implementing dietary and other anti-obesity treatments. Lifestyle interventions with diet and increased physical activity are the cornerstone in the management of NAFLD. Medications can also be used, which include insulin sensitizers and antioxidants. Bariatric surgery has also been proven to be one of the most effective weight loss treatments and improves the survival in those with morbid obesity. Bariatric surgery and NAFLD. It has been widely acknowledged that the patients undergoing bariatric surgery have high rates of NAFLD. Steatosis is thought to be present in approximately 90% of morbidly obese patients and steatohepatitis. The two most important questions in managing patients with NAFLD are 1. Does the patient have simple steatosis or NASH? And 2. What is the stage of fibrosis? Bariatric surgeons have the unique opportunity and ability to address these questions via an intraoperative liver biopsy. Intraoperative liver biopsy can help differentiate between simple steatosis, NASH, and varying degrees of fibrosis. Bariatric surgery leads to overall improvement in the metabolic syndrome associated with obesity. It also reverses the fatty infiltration within the liver and arrests simple fatty liver progression to NASH. Overall, the topics covered in this video included liver and its functions, obesity, how obesity affects the liver, non-alcoholic fatty liver disease, prognosis, clinical presentation, risk factors, diagnosis, treatment, and bariatric surgery. I hope that this video has provided you with valuable learning. Thanks for watching.